Is it useful to know every genetic mutation a patient has?
So, there are lots of genetic mutations that will not affect what we do clinically, and that we may not know the full meaning of that mutation in terms of its effect on a patient's prognosis. So, in short, the answer is no. However, as we're, learning more and more and making more advances, it is possible that a gene that's not relevant today may be relevant down the road.
I think the answer is yeah, definitely yes from my standpoint. Even though that there is not huge therapeutic or targetable mutations in MDS currently, the prognosis and our understanding of the prognosis based on molecular mutation is there. And so really getting those tests, much better help predict what patients are going to do well, what patients maybe are not going to do well, and I think there's certain molecular subsets where, if we know that they're not going to do well, we're really thinking, okay, you might need a clinical trial. One of those is TP53 mutant MDS. And so that's a molecular subset that we really kind of know, is probably, they might respond to therapy, but the response is not going to be sustained. And so we're trying to look, okay, in TP53 mutant MDS, we know we're not going to be able to get a sustained response. Can we do better? And so that's where we're directing patients to clinical trials using new agents to be able to target that. Another example would be, ASXL1 mutations. So ASXL1 is another, adverse risk mutation in myelodysplastic syndrome. And what we know is that, if it is a higher risk patient and we're trying to use what would be considered the standard of care therapy, which would be a hypomethylating agent, we know the response rate in those patients is extremely low. We're talking, depending on what study you're looking at, somewhere between 0% and probably at the highest end, maybe 30%. So another subset where we need to do better. And, I think, that's with clinical trials, whether it's with, venetoclax, which is an oral BCL2 inhibitor, or other novel agents. We're able to potentially improve the response rate, improve our ability to potentially get patients to, bone marrow transplants, which is the only way that you can cure myelodysplastic syndrome. And so genetics are extremely important. And like I said, the IPSSM is driven by genetics. And so, without that information, I don't think you can really confidently and accurately feel like you're making the best therapeutic decision and really telling the patient, all the information they need to know about their prognosis.